And this is Dr. Destunis. I'm going to finish off with my last talk, ultrasound of papillary lesions and nipple discharge. I want to thank Dr. Mike Ulisi and the NDIS team for the invitation and the honor of presenting to you. And I hope to see you physically sometime soon. We're going to move on to discuss a bit of a background of basically what papillary lesions are and what we mean when we say papillary lesions of the breast. They have presence of a fibrovascular core surrounded by cells. Most of these lesions are intraductal. They can be malignant, but mostly are benign based on presence or absence of whether there are myoepithelial cells in the papillary core. The immunohistochemical stains for the myoepithelial markers are very useful for the definitive diagnosis because the pathologic diagnosis on core needle biopsy can be quite challenging. I do have some references, which also will be at the end, that are very helpful to discuss, papillary breast lesions. When we talk about them, we're looking at intraductal papillomas. We're looking at papilloma with atypia, papillary DCIS, also solid papillary carcinoma. These have or don't have invasion associated with them, and encapsulated papillary carcinomas with or without invasion. This is the WHO classification when we're looking at intraductal papillomas versus papilloma with atypical ductal hyperplasia, or DCIS, or papillary DCIS, or encapsulated papillary carcinoma, mucinous cystadenocarcinoma. So you can see that the myoepithelial markers and the hormone receptors really are quite significantly different and play a large role in how these are categorized. The differential diagnosis for these frequently can be quite similar. If we look at intraductal papilloma, the differential may be papillary DCIS and nipple adenoma and adenomyoepithelioma. Let's look at papillary DCIS papilloma, papilloma with atypia, papilloma with DCIS, or adenomyoepithelioma. So these can be quite a dilemma in diagnosis. Papillary lesions are investigated with ultrasound very frequently because ultrasound has a greater sensitivity for detecting papillary lesions, more so than mammography. We're looking at presence of dilated ducts associated with a mass. That may be a good indicator for a papilloma, and also a useful sign to tell us whether something is intraductal and a papillary lesion from other lesions. New had a nice study about papillary breast lesions detected using ultrasound. And this was published in European Journal of Radiology in 2021. And they looked at lesions that were greater or equal to 1 centimeter. These were more likely to be malignant, they thought. If you have an ill-defined margin, it was more likely to indicate atypia or a malignancy. Ultrasound, Doppler ultrasound elastography improves specificity for these papillary lesions. Both Dr. Zhu and Dr. New thought. These are some nice studies that have been published over the years. Well, what are we looking at when we're looking at the profile with ultrasound? Well, we may be looking at an intraductal mass that may have ductal dilatation or not. You may be looking at an intracystic mass or a solid pattern in an intraductal mass completely filling a duct. Some reports actually have found the shape of the lesion may be predominantly round or oval, and the margin even be circumscribed. However, it may be non-parallel, there may be an echogenic halo, or a posterior acoustic enhancement, or even calcifications. More likely, these will be found in malignant cases as compared to benign. So, if it's non-parallel, if it's an echogenic halo, posterior acoustic enhancement, calcification, those are associated features that you may see with these papillary lesions, and that would signify more likely a malignancy versus a benign entity. So these are pretty, these additional features can really increase the sensitivity and specificity of defining the papillary lesion with ultrasound. Well, how about intraductal papillomas? Well, we have solitary intraductal papillomas. They may be associated in the retroareolar region or centrally. They may present with clear or bloody nipple discharge. And these are intraductal papillomas, solitary ones. You may see a dilated duct with some hypoechoic content within it or a mass that has a relatively well-defined border. If you have multiple intraductal papillomas, the wonderful authors that published this in the last several years tell us these are papillary proliferations that may have kind of multiple terminal ductal and lobular units. They're usually peripheral. They are rarely associated with any nipple discharge and usually may present with a palpable mass. More frequently, these may have atypia or carcinoma associated with them, the multiple intraductal papillomas. This is a patient that's 50 years old and she comes in feeling a new lump. She has a history of papillomas in that left breast. And you can see the marker is over another mass, but she does have several other masses in that left medial aspect of the breast and left central breast. So we went ahead and did ultrasound. So you can see that she has multiple papillomas. Some are, hypoechoic masses, and then there's a rim of fluid within them. But this patient is feeling, the area she's feeling is in the left medial breast, 3 centimeters from the nipple. And so this is her area of concern. So left 9 o'clock, 3 centimeters from the nipple, and also left 9 o'clock, 1 centimeter from the nipple. So we did a biopsy of what she was feeling, and this was an intraductal papilloma, in addition to all the other ones she already has that we've known about. Well, what about having a papilloma with atypia? Well, these are associated with the high risk of carcinoma if you do have atypia, whether it's atypical ductal hyperplasia or atypical lobular hyperplasia within the papilloma. So these are recommended to be excised. This is a 50-year-old, and she presents, she has a mammogram. You can see here she's had an autologous reconstruction after mastectomy of the left breast. And she comes in because she's asking for an ultrasound. She has dense breast tissue on the right. We read this mammogram as negative, no change from her prior films. So we went ahead and did the ultrasound. So her right breast has this hypoechoic mass that you can see here at 11 o'clock. So we biopsied this under ultrasound since we see it so well under ultrasound. And this was a typical papilloma with a negative mammogram. So what happens with these atypical papillomas? Well, these atypical papillary lesions, they have a very complex kind of histologic pattern. They may have a fibrovascular core. There may be a myoepithelial layer. There may be an outer layer of epithelium. And so when you look with imaging, we cannot distinguish between a benign or malignant lesion. And nice reviews by Tavasoli, Rosen, and Foley tell us that areas that may be atypical carcinoma in situ or even invasive cancer can be present in a papilloma. If you have atypia in a papilloma, it should be surgically excised. You can see here what the pathology slide may look like for a benign papilloma versus an atypical papillary lesion. And you can see that there are multiple small photographs of what these atypical papillary lesions may look like. Atypical papillary lesions, how about if you have a benign papillary lesion? Well, a study by Tatarian looked at 119 benign papillomas. We know that if they do have atypia, there is a high risk of cancer. But how about if they don't have any atypia? So 119 benign papillomas. This was a study done in 2016 and published in the Annals of Surgical Oncology. And 75 of these benign papillomas were surgically removed. There was a 2.7% upgrade to cancer and 21.3% upgrade to atypia. So upgrade to cancer was kind of rare, 2.7%. However, over 21% were upgraded to atypical. That may change management for these patients. So even with the benign, you can't discount it altogether. Foley in 2015 looked at 238 cases over a 4-year period, and they looked at their upgrade rates of benign papillary lesions. Well, they found 14.4% upgrade to malignancy. 25% of those were invasive. The overall risk of malignancy was higher if older age and presence of any atypia on the core. So if you have a low-risk patient, let's say a younger patient with no atypia on your core biopsy of your papillary lesion, you could probably avoid surgery and do surveillance. However, if the patient's older, if there's any atypia, they got to come out. And so the studies kind of agree on this. This is a 69-year-old. She comes in for routine screening. So if you look, we did magnification. This is the ladder magnification view for calcifications. They were, in the subareolar area. So we biopsied them with stereotactic needle biopsy vacuum, and this was an intraductal papilloma with atypia. She's older. It's atypical. It came out. So on surgical excision, this was ductal carcinoma in situ papillary type. What about these papillary carcinomas? They're about less than 1%, 0.5% of breast cancers. The papillary proliferation of the breast as cancer, they don't have an intact myoepithelial cell layer. And that's an important feature to distinguish it from a benign intraductal papilloma. But they're a small percentage of breast cancers. Looking at papillary DCIS, less than 1% of all breast cancers in women. Typically, you may see nipple discharge, often bloody. On ultrasound, it may be a complex intracystic lesion, solid, round or oval mass that has, circumscribed margins. There may be no myoepithelial cells. Does not necessarily indicate invasive cancer having a lack of a myoepithelial layer. Typically, you don't see papillary DCIS on ultrasound. And this is a nice study by Golestani that was published in Clinical Breast Cancer just this year, talking exactly about papillary DCIS and the papillary architecture with or without associated invasive cancer. Solid papillary carcinoma, less than 2% of all breast cancers. Typically, postmenopausal women, you may see something round, oval, lobulated. There may be calcifications within the tumor. They can be coarse or pleomorphic. On ultrasound, it may be some complex solid mass or a complex cyst. The WHO recommend that these solid papillary carcinomas are treated as ductal carcinoma in situ. And then encapsulated intracystic papillary carcinoma is typically circumscribed, encapsulated from the surrounding stroma. It has a fibrous capsule. It's similar to invasive carcinomas, but usually it's managed like an in situ carcinoma. And ultrasound here is very important because it shows an irregular wall of this encapsulated area, thickening in a cyst possibly, or an intracystic parenchymal proliferation that will look suspicious. Here we have a lesion in the right 930 o'clock area. This was palpable. The patient came in feeling it. You can see it in lung and trans. This is a hypoechoic. You can call this microlobulated diffusion-like mass, although there may be some angular margins here. So this was encapsulated papillary carcinoma on ultrasound guided biopsy. Invasive papillary or micropapillary carcinoma is extremely rare, and it usually will present as a round, oval, or lobulated mass. And if it is micropapillary, it may have spiculated margins and it may have calcifications. These invasive micropapillary cancers will have axillary lymph node metastasis and then typically have a worse prognosis, but they typically are rare. There was a very good article by Nunes in Breast Cancer Management a few years ago discussing this very rare presentation. So I want to show you a bit of a conundrum for one of our patients that we followed. The patient came in for a screening mammogram and screening ultrasound. It was identified that she had an area that the radiologist felt maybe a cluster of cysts, perhaps some debris within the cyst, inspissated material. Once the area was identified, the patient said they were tender over the area on ultrasound, and aspiration was performed. The area drained, the patient went home, but then the patient called about 4 to 6 months later, wanted to come back in for a reevaluation. So here is somewhat of a 6-month follow-up ultrasound at patient's request. You can see that the cystic areas have gotten larger. You do have this solid hypoechoic eccentric irregular area. So this was biopsied under ultrasound. The solid aspect of it was intraductal papilloma. So patient goes home and then comes back for a follow-up ultrasound in 6 months. She's bothered by the increase in size of the cystic component of this. So requests an aspiration is performed and goes home with her papilloma. Comes back at her year follow-up, more fluid in the area. We can still see the solid component, requests an ultrasound again, and also requests drainage. So at this point, the radiologist discusses, well, this papilloma, this papillary lesion will keep on creating more fluid. We recommend you see a surgeon. That's at her year follow-up. She decides to not go to a surgeon, but the area is getting bigger, more fluid. So she comes back 4 months after her year follow-up and after the surgical recommendation and wants to drain. It's drained again. The fluid keeps getting sent off to the lab. We've already biopsied the solid area. Comes back again 4 months later because the fluid just keeps reaccumulating. Wants the fluid drained. We requested that we do a vacuum of the solid component at this point. Since she's not going to a surgeon, she did not want a repeat needle biopsy of the area. And then 4 months later, comes back again, as you can see. So the fluid just keeps on reaccumulating, and we keep on draining and keep on recommending she see a surgeon. And then 6 months later for another follow-up. So at this point, we told her that, okay, we're going to have to vacuum this area out, or you're going to have surgery. She's refusing surgery. So we perform a 9-gauge vacuum of the residual intraductal mass again. And this was an intraductal papilloma. So you can see that these can be quite difficult management for the patient and for the radiologist at times. And so here she comes back again 14 months later, tons of fluid. These are clearly palpable, causing her, quite a bit of symptoms, and just keeps wanting the area drained. So lots of conundrums. So here we go post-aspiration with the residual papilloma that's grown again after original needle core biopsy, and then vacuum, where we tried to remove as much as we could. But obviously we got, again, recommending the surgical excision on the patient. And this time she finally did have it out. What about dilated ducts, where they may be present in patients that have nipple discharge? In the 5th edition of our atlas, it was endorsed that if you have a solitary dilated duct, if you don't have a benign etiology, then tissue diagnosis is recommended. Newer literature also confirms that a solitary dilated duct is usually pretty rare. And if it's not associated with any suspicious imaging features like an associated mass or architectural distortion or microcalcifications, it is benign. So if the patient's a screening, it's a very low likelihood of malignancy and can be considered benign. But if the patient comes in with bloody discharge or clear discharge or other suspicious imaging findings, then you may want to do a tissue diagnosis of this dilated duct. Nipple discharge is quite a common symptom that can present in many ways. It's the 3rd most common breast complaint after pain in the lump, and its prevalence can be as high as 7.4%, with 50 to 80% of reproductive age women having at least one episode of discharge in their lifetime. So if your imaging yields a diagnosis like intraductal papilloma or malignancy, surgical excision is obviously recommended, because even if it's a benign papilloma, to resolve the discharge. Women may have physiologic bilateral express discharge or spontaneous, multiple ducts, milky or straw colored, but clinically suspicious discharge pathologic discharge may be single duct, spontaneous, clear, or bloody, most suspicious usually. There are many ways to approach, having a pathologic type of discharge. Ductography is a procedure that can be done if a patient has nipple discharge at the time they present. You inject non-ionic contrast in a retrograde fashion after you cannulate the duct, and that helps visualize the duct. And then you go ahead and image the area with X-ray. Our ACR has, criteria of how to handle, this is adult male or female, 40 years or older with pathologic nipple discharge. Initial imaging, ultrasound of the breast is usually appropriate. Digital breast tomosynthesis diagnostic, usually appropriate. Mammography diagnostic, usually appropriate. And everything else, ductography, image-guided core biopsy, or FNA or MRI, or sestamibi, or everything else is usually not appropriate. We start with ultrasound in these patients if they're in their 30s, of course, under 30 for sure, start with ultrasound. But we manage discharge. We frequently will do ductography if they have active discharge. If it's new, we'll do a mammogram, a breast exam. We may send slides of the discharge. And ultrasound is definitely a very important tool to make a decision. Ductography may reveal something that we can biopsy. So when do we use ultrasound to evaluate nipple discharge? It's a wonderful complement to the mammogram, and it may be the initial exam in young or pregnant or women that just had a mammogram and it was normal. If the ductograph then we may end up doing is positive, we will also do ultrasound to look and see what else we may see with ultrasound. When we evaluate discharge, we'll frequently electronically fill out a paper, right and left breast. We'll express from both breasts and document the color, the duration, and how many ducts we're able to get fluid from. This is what a normal ductogram may look like. This is a patient that came in, 40 years old with green colored discharge, single duct that she expressed for 2 months. You can see the fanning of all these normal ducts that are filling with the contrast material. There's no dilatation. There's no filling defects. However, this is a 50-year-old with 2-week-long spontaneous bloody discharge, and she had multiple filling defects that you can see with the arrows here. Let me go back to it because it advanced on its own. And this was ductal carcinoma in situ and also invasive disease, all these filling defects. So you can see how dilated this ductal system is, how many filling defects are that I don't have the yellow markers on. There are multiple little bites of these ducts, eccentric, irregular. So this is cancer. So we can diagnose with ultrasound a small solitary intraductal papilloma. We can characterize something we see on the mammogram, and also we can do ultrasound-guided biopsy. In a study by Al-Hadathi, all confirmed malignant lesions were seen as suspicious by ultrasound, and there was a significant association if an ultrasound of BIRAS 4 and 5 was seen, and also if there was malignant cytological impression. So ultrasound found the malignancies that were papillary lesions, and it was helpful in identifying whether it was just ductectasia or fibrocystic disease that may help explain the nipple discharge as benign. And ultrasound is important to utilize even if your mammogram is negative. So we don't want to forget that. So ultrasound, very important. So common causes of pathologic discharge and intraductal papilloma, up to 48% of the cases may have this intraductal papilloma as a finding, and ductectasia, 17 to 36%. Underlying malignancy can be found in 5 to 21% of the patients that have pathologic discharge and undergo biopsy, and the risk of malignancy will increase with increasing age. So you can see here, this is an intraductal papilloma. This is a ductogram. The contrast fills this dilated duct, and then we have a filling defect where the small papilloma is. This is a 60-year-old. She comes in because she had bloody nipple discharge from the left breast. And you can see that we're imaging after we have cannulated, and there's contrast in this dilated system right behind the nipple. And you have some pulling of the contrast right in the nipple. We did not see any discrete filling defects. We went on to ultrasound, and right at the tip of the nipple there in the subareolar area, there was, you can see partially cystic solid mass right in the nipple region. So ductectasia, intraductal mass. So what do we do with that? Ultrasound guided biopsy, intraductal papilloma. This was excised because this patient, was symptomatic with this, and this was a solid papillary carcinoma on excision. So the mammogram was normal. The ductogram wasn't that helpful, but the ultrasound was extremely helpful in this patient. And these are my references. And I want to thank you for your time. And I really appreciated the opportunity being here with you. And please email me if you have any questions, sdestounis@awbc.com. Thank you again.